Hi, welcome to our HIV quarterly brief. This is the third quarter, 2022. Joining me today, I'm delighted to introduce Dr. Eric Dar, who is the chair of HIV medicine at Harbor UCLA and professor of medicine there as well. Eric, welcome.
Thanks, Paul. It's great to be here with you.
Super. So we have a lot to cover, which is always a great thing to say because sometimes people say, oh, in the COVID era, there's not much moving forward in HIV, but in fact, there was a lot, very interesting stuff. Some of it, of course, was presented at the Montreal International AIDS Conference. But let me just start with talking a little bit about something that's related to HIV, and that's the MMWR's recent report on HIV, STIs, and monkeypox. I think I want to underscore something in particular about monkeypox, and that is, first of all, good news, the cases seem to be declining. That's very good news. But second, there was just recently a report of really severe cases in people with untreated HIV, mostly with advanced HIV disease. And Eric, I wanted to just get a sense from you out in Los Angeles. What has been your experience with this really new sexually associated infection in the HIV population?
Yeah, well, it was pretty dramatic for a while. It's really palpable how things have changed, right? We had a point where, because big part of what we do is see people in an HIV clinic, and the populations are identical to the population that's been affected by this. So we literally had people who are walking into clinic for a routine follow-up visit and saying, oh, by the way, I've got this rash. So we're seeing it regularly, seeing people drop into the emergency department and urgent care, and suddenly it's slowly starting to dissipate. The cases we saw are very much like what's been described. People with scattered lesions, lots of genital lesions, perianal lesions, and mostly a lot of discomfort. Fortunately, our patients have all done well, but we are in Los Angeles do have the one case of a patient who is reported to have died from monkeypox, but was also noted to be severely immunosuppressed.
Exactly. I think that's the important part of this latest CDC warning, is that this overlap between HIV and monkeypox is particularly concerning for the patient population not on ART with advanced immunosuppression. We also should mention at least that there's an open clinical trial for people with mild to moderate monkeypox, and that's a study of the drug tecovirimat, which has been given under sort of a compassionate release, but it is really something that we don't know if it works. So it will be good to enroll people in this study if possible. Let me mention also that the Department of Health and Human Services updated their living document, which is their HIV guidelines. And let me just highlight a few of the changes that I think are worth underscoring. First, they do mention that people who fail post-exposure prophylaxis with cabotegravir, that they should have baseline resistance testing, not surprisingly, but it's baseline resistance testing that includes the integrase inhibitor drug class, which of course is such a key component in all initial regimens. Not surprisingly, they've gone in concordance with the perinatal guidelines and removed all the language about the dolutegravir and neural tube defects. It appears that story has finally ended. And then I do want to mention also that there's now a formal acknowledgement that you can actually do resistance testing for people whose viral loads are greater than 200. You don't have to wait for it to be greater than 1,000. It's a really acknowledgement that the partial activity of the nucleosides is sufficient in people who have fully active high resistance barrier drugs. You think that's really has changed clinical practice, hasn't it?
I think so. And it is a pretty substantial addition to these guidelines. And it's mostly incorporating the Nadia data, both for people who are experiencing virologic failure, opening the door to a high barrier integrase like dolutegravir with even partially active nukes if you don't have a fully active nuke to with it, and then to extrapolate that to the population you're saying, and those are the people suppressed on a boosted PI with only partially active nukes.
Yep.
And recognizing that they will probably do as well with the second generation integrase.
All right, now totally changing the subject. Let's go now to something that was presented at the Montreal AIDS Conference. Take us through this next case of HIV cure.
Yeah, so cures have been few and far between, but there have been some, which is great. And obviously the one everyone's most familiar with is Timothy Brown, who was off antiretroviral therapy after a bone marrow transplant from a donor who was homozygous for the CCR5 delta 32 deletion, and really did appear to be cured after more than a decade off therapy with multiple samples tested. And attempts to cure people using other strategies, a little less promising thus far, but there have been a few cases where they've replicated the experience with Timothy Brown. And this is the most recent one. This was a patient here near where I live in Southern California in Los Angeles at the City of Hope, who was a 66-year-old man who had acute myelogenous leukemia, who needed a bone marrow transplant and was able to get one, a matching donor who had this unique genotype where they were CCR5 delta 32 homozygous cells that are largely resistant to HIV, and ultimately was able to interrupt his therapy. And they reported data after 17 months without rebound. They did a lot of intensive sampling, as they always do in these cases, and they described a little bit of spurts of detectable genetic material in cells and in gut, but just low levels and intermediate and of unknown clinical relevance. So 17 months is pretty good.
Yeah.
And based on the other data, I think a lot of promise. Obviously, not a strategy for the masses, but it's a continued proof of principle.
I do want to mention another form of like almost cure, and that is this patient presented at the meeting of someone with sort of what they describe as exceptional elite control. And this is a 59-year-old woman who at baseline, when she had acute HIV, had a HIV RNA of only 70,000, which is pretty low for acute HIV, and then was enrolled in a clinical study of ART plus this grab bag of immune-based therapies. And then eventually she underwent treatment interruptions, actually first a treatment interruption and then another treatment, then treatment back on. But then the next treatment interruption was 15 years ago, and she has not had any viral rebound. Now, she did have a positive quantitative virus outgrowth assay, or QVOA, at year 9 of the interruption. So she still has HIV, but I think you could say that this is kind of like a functional cure. And interestingly, unlike some other elite controllers, this case does not have any of the favorable genetic factors that are sometimes seen. So what do you think? You've studied treatment of acute infection. What do you think of this case?
Yeah, people are talking increasingly about sort of sustained virologic remission as the viable strategy, as opposed to true sterilizing cure. And, this is a pretty long run, 15 years, in somebody who there is evidence probably still has some residual virus in their system. So it's probably a wonderful example of that. It's always hard to know with these anecdotes how much the intervention actually drove the outcome.
Let's now shift to HIV treatment, and I'm going to start with a study that was published in a highly respected IT journal called Clinical Infectious Diseases. It's an observational study looking at a large number of people started on ART in Africa. It was 29,000 people in 63 sites, and looking at the predictors of loss to follow-up and viral suppression with a particular focus on time of ART initiation. And we've all heard about the same-day ART initiation. And what this study found, somewhat paradoxically, is that there was actually an association between same-day ART initiation and loss to follow-up. And there were actually higher rates of loss to follow-up among the people who started ART the same day. I think, encouragingly, there was no difference in viral suppression. But basically, what I think this is telling us is that even though same-day ART initiation is fine to do if you can do it, and if the patient wants it, it's not absolutely mandatory. I think that may have been a message we conveyed a little too strongly. So anyway, this I think we should individualize is essentially what this paper is telling us. Some people you can start ART right away, and other people it's okay to maybe wait a little while. I don't think it should be delayed unnecessarily, but starting the same day may not be necessary. Your thoughts?
Yeah. I mean, it's really hard to extrapolate this to our setting. It's impossible for me to believe that starting them early will reduce the likelihood of them being retained in
Yeah.
care. I can't be sure it will increase the likelihood, but I can't imagine it will hurt. And the downside of treatment now, because it is so well tolerated and has such a high barrier to resistance, is really nil.
Yeah,
So we are
exactly.
doing it. Anytime a patient says they're willing and interested and sort of has a plan for follow-up, they don't have to prove it, just state that they have a plan. We will encourage them to start.
Now, onto a very different population. Eric, tell us about what Ward 86 is doing with some of their difficult and to treat patient population.
Yeah, so this was also presented at the International AIDS Conference. It was really interesting. So, the background is we now have these long-acting therapeutics, cabotegravir, rilpivirine, that are given every 8 weeks for treatment. And many people thought, well, gee, this seems like it makes perfect sense for those people who are poorly adherent or have trouble with pill taking.
Yeah.
The challenge is that's not who was studied. And we know that it is really important for this population that they come in on a regular basis to receive their treatment, or they risk having that long tail of drug and potentially selecting for resistance. So what they've done is they've identified a population of challenging patients, those who are often have unstable housing and are using substances, and they bring them into the clinic and offered them treatment. And they reported at this conference the first a little less than 40 people who came in and got 2 doses or more. And the interesting part of it was that there were 15 who were not suppressed on antiretrovirals, but because they were challenged by taking their medications, they went ahead and did it. And then they reported that 12 of the 15 didn't achieve and maintain for some finite period of time some suppression. So it's early data in small numbers. It's hard to say whether it's a home run or a great strategy, and how much selection goes into the population they actually chose to intervene with. And I don't think this is something for prime time or that we should be doing as a matter of routine. But it's great it's being done.
I think it's a fascinating case series and sort of testament to the kind of wraparound services that they can offer in their clinic. I want to mention that most places that are delivering HIV care don't have the resources that they do. And even those that do may practice in settings where access to the rilpivirine for people who don't meet the FDA approved criteria might be difficult. All right, now on to a topic that bedevils HIV clinicians everywhere, and that's low-level viremia. And there's been a lot of studies looking at what the prognostic impact of that is on long-term virologic success. And this European multi-center cohort study looked at this over time and found, as other studies have shown, that there in fact is an increased risk of virologic failure for people who do have low-level detectable viral loads versus completely undetectable all the time. Now, I am totally on board with these results. I completely believe them. I do want to mention a few limitations. First is that this study, a lot of the people in the study were not integrase inhibitors, and now we have high resistance barrier integrase inhibitors that are used in almost everyone. And the second is studies like this cannot separate out the people who have low-level viremia because their adherence is sort of so-so, versus those who have low-level viremia and because they have a very high baseline reservoir, and so they have this pool of latently infected cells that occasionally have detectable virus in them through our sensitive assays. And there's a very big difference in those populations because the latter, the people with the high reservoir, are often 100% adherent to their treatment. We know that intensification does nothing, and they don't evolve resistance. So I think that the take-home message is, yes, low-level viremia has some prognostic significance, but we don't yet have a strategy for how to manage them. I don't know what you do when you have a patient with this result that comes back like this.
No, I think you're exactly right. That's the key issue, is we don't know what to do with these people. And in the past, our experience had been mostly negative, flogging them with more drugs, modifying therapy, attempts to sequence people with very low levels of virus. And I do think that we did a lot more harm than good. I think the one thing I used to suggest back in the day was I personally would make sure they're on a high barrier drug. But at this point, like you say, everybody is on a high barrier drug.
Yeah.
So it doesn't even apply.
Okay. Now on to new antiretroviral therapy. And let me just bring up islatravir. And first, an older study. It was published online in 2021, and it shouldn't really fit in this quarterly brief, but it's been updated recently. And it's the use of islatravir doravirine in the phase 2 trial. And the reason why it came up is that there's now the last line of the paper, which is published in Journal of AIDS, now reads, note added in proof, in light of lymphocyte reductions observed in other clinical studies of islatravir, a post hoc analysis of total lymphocyte count was conducted while this article was in production. And at week 96, the mean change from baseline in total lymphocytes was plus 0.24 for the lowest daily dose group, and that's the 0.25 milligram daily. And so this led to a press release from the company that's developing islatravir, and that they will now be proceeding with their doravirine islatravir 2-drug regimen with this low dose. And that is actually important that they're going to move forward with it. And not only that, they are going to resume their study of islatravir with lenacapavir in a once-weekly dose. So it may have been a dosing issue, and that's what we're hopeful, and that it's not intrinsic to this nucleoside reverse transcriptase translocation inhibitor, either molecular structure or mechanism. But I'm glad to hear that this hold on islatravir is off, and they're going to move forward with treatment. Eric, what about their prevention studies?
Yeah, so it had great promise for prevention, and we'd seen some data suggesting pharmacokinetics were very promising for things like monthly islatravir, a pill that you could take once a month for potential prevention, or an implant that could be given maybe or placed perhaps infrequently as once a year. But I think because of these concerns and the fact that for prevention, you're treating somebody who doesn't have HIV and otherwise healthy, it sounds like at least in their press release, that they're not planning to move forward with any of the prevention work.
All right, shifting now to ART in pregnancy.
There were several studies that I'll briefly touch on that I think were important that came out of the recent International AIDS Conference. And the first one was a follow-up in HPTN 084. And everybody remembers that there were these two companion studies, 083 and 084, that were conducted looking at long-acting cabotegravir, 083 in MSM transgender women and 084 in cisgender women. And both studies were stopped early because of superior efficacy with the every 8-week injectable product versus daily oral. What we saw was the follow-up on 084, where as they were transitioning those in the oral group to the injectable, they had continued follow-up. And basically, they showed that reduction in risk of incident infection by over 80% seen during the blinded phase continued to be seen during the open label phase, with no infections documented to occur in people who are actually getting the medications appropriately. And the other thing that was nice was that they were obviously looking closely for pregnancies, because it's a risk population that has the potential for pregnancy. And they were able to at least report on the first 120 plus pregnant cases. It turned out they were evenly split between the oral therapy and the injectable, and they really were unable to document any concerns, at least in those populations, which is promising for women of childbearing potential who may be looking to use this as a prevention strategy.
Definitely.
And then along the lines of pregnancy, we already started to talk a little bit about the dolutegravir story, and we saw the update. As you mentioned, it all started about 4 years ago, where it was reported that there was almost a 10-fold higher risk of neural tube defects in women who received dolutegravir at the time of conception, but the numbers were tiny. The numerator was 4 and the denominator was about 400. They've now expanded that, and the incident rate just continued to decline from 0.9 to 0.6 to 0.3 to 0.2. And the most recent one with 9,000 plus exposed individuals was 0.1, which is essentially what it is for everyone else. So I think this is another reminder that we always need to be careful with small numbers. So it was an important event that needed to be chased down, but the good news is I think it's over.
Great.
The last study was another that was recently published in the New England Journal. It was a study primarily done in the US where they looked at use during pregnancy, including at the time of conception. And they looked at data in women who received dolutegravir, boosted atazanavir, darunavir, rilpivirine, raltegravir. And basically what they showed, including half of whom were exposed at conception, was, viral suppression was better with dolutegravir than with some of the other options like atazanavir, ritonavir, raltegravir, and boosted elvitegravir. So reminding us that this isn't an even exchange, that there are true advantages, virologic suppression, with drugs like dolutegravir. And then they also were able to look closely, including at those exposed at the time of conception, and they saw no difference in preterm births, low birth weight, or small for gestational age. So no real concerns about potential toxicity.
Yeah, I was very glad to see that paper because most understandably, most of the studies of pregnancy in women with HIV come out of Africa, given they have the largest number by far. But we have some in the United States too, and a broader range of treatments. Of course, what's missing is bictegravir, and we all have had patient after patient who gets pregnant on bictegravir, since that's such a commonly used treatment right now. I'm hopeful that there will be enough data accumulating over time so that we could remove that not enough data category for bictegravir in use in pregnancy. Let me talk about another study that sort of falls into the potentially practice-changing category, which is always exciting, and it was something I had not anticipated at all. It was called the Alliance study, and it was a phase 3 comparative trial of bictegravir FTC TAF versus dolutegravir plus FTC TDF. And it was done in predominantly in Asia. Most of the people were enrolled in Asia, and the overwhelming majority of people in the study were men, and it was, had to have HIV and hepatitis B co-infection. That was the absolute requirement. The virologic results for HIV were the same. And what I wasn't predicting was that the hepatitis B results would favor the TAF intervention. And so the primary endpoint for hepatitis B was viral suppression, and at week 48 it was 63% in the bictegravir FTC TAF arm and 43% in the dolutegravir plus FTC TDF arm. But when you looked at the other kind of endpoints that are hepatitis related, they also favored the TAF arm, and that was ALT normalization, e antigen loss, and surface antigen loss. So, I looked at these results and thought, even though it's just week 48, even though there are some outcomes in hepatitis B that take longer than HIV, I think these results favor TAF enough that I would use TAF preferentially over TDF in people with HIV hepatitis B co-infection. Any thoughts about this study, Eric?
I mean, fortunately for most of us, that's not been an issue, and that we've been able to use TAF instead of TDF for other good reasons. For settings where that may be more challenging, it will raise issues. Obviously, it would have been a better study design if they'd used dolutegravir, TAF FTC versus TDF FTC. Would have been a cleaner study design, but this is the data we have. All things being equal, I'd use TAF. I'm not sure if I couldn't use TAF, I would lose a lot of sleep over it.
And again, the study is just presented. It hasn't been published. Now on to another, we're shifting to co-infections. So why don't you tell us about other STIs, Eric?
Yeah, so the study that got a lot of attention at the meeting, and rightfully so, was this ACPE study. And it really is aligned nicely with what we've talked about already. To me, it complements very well the concept of U equals U in PrEP. This was a study from San Francisco and Seattle where they did a follow-up study from a French study, a smaller one, where they basically took high-risk individuals who were either on PrEP or had HIV, high risk for acquisition of STIs, and they randomly assigned them 2-to-1 to either received 200 milligrams of doxycycline within 72 hours of condomless sex or not. And what they showed was about a 65% overall reduction in incident STIs. And this was true of the reduction for all three, chlamydia, gonorrhea, and for syphilis, amongst those who received doxycycline versus those who didn't. In fact, the DSMB stopped the study prematurely because of a highly significant reduction in STIs. It was well tolerated. It was very well accepted, at least based on what was reported. They tried to look a little bit at resistance, which is one of the concerns we all have about more widespread use of doxycycline. And at least an early look for GC resistance didn't suggest trends that are higher than what's seen in other standard surveillance surveys in the United States. So far, so good. But there is baggage with this. Not just drugs and drug cost, which isn't much, but really this issue of resistance if it's used frequently over time. So I don't know, Paul, what your thoughts are about how we could think about implementing this in clinical practice.
I would say that, if you do much PrEP work or HIV clinical care, you know that there are people in your longitudinal care pool who get frequent STIs, and I would probably start with that group. I wouldn't necessarily make it for everybody, but I agree. I share some of your concerns about the resistance, especially with gonorrhea. I mean, obviously, globally, gonorrhea has tremendous resistance, but already, including in Europe, where this intervention, as you mentioned, didn't work. So for gonorrhea, but I am cautiously optimistic. It'll be of real benefit for some of our frequent flyers in the STI treatment area. So on to the last study we're going to cover, and that's going to be another complication, infectious complication in our HIV population. It's the cerebral toxoplasmosis. And, all of us who do HIV medicine, you learn about the optimal treatment of cerebral toxoplasmosis as pyrimethamine and sulfadiazine. And you have to give that with folinic acid, and it's a complicated 4 times a day treatment. So pyrimethamine sulfadiazine is a big pain. And so how does it compare to trimethoprim sulfa, which has been used globally for treatment of toxoencephalitis for some time? And so I got to hand it to these Canadian investigators. They basically did a systematic review of 6 randomized clinical trials and 26 cohort studies. And this included 1,959 people treated for toxoencephalitis. And what they found was that there was comparable radiologic response, comparable clinical response, but the discontinuations due to toxicity were much lower in the trimethoprim sulfa group. And there was also a trend towards better mortality. So, to my mind, we're never going to have, I don't think, a large enough comparative clinical trial of these two approaches. So I would look at this paper, which again was published in CID, if I were on the guidelines committee, and say, look, we should say that these two options for toxo treatment are at comparable at least, and probably the trim sulfa is safer, and it's certainly less expensive. Your thoughts?
I completely agree. I think this opens the door for us to feel comfortable using it. I mean, my reluctance in the past was there's so much at stake to document a response to empiric therapy here that I wanted to make sure that they got the best shot. And I think this data really provides us information saying that trimethoprim sulfa may be as good a shot as pyrimethamine sulfa, at least.
Yeah. I should also mention that every so often our colleagues who do transplant-related infectious disease will see a case of cerebral toxoplasmosis or toxoplasmosis encephalitis, and they've been using trim sulfa for a while. So it's time for us in the HIV community to have the same option. So Eric, I really want to thank you for joining me on this quarterly brief. As always, it's great to talk new HIV clinical data with you. You provide great insights as well as real kind of practical clinical applicability. Thanks so much for joining me.
Thanks, Paul.